Well, this is just a general state-of-the-art for the past year. So I decided to turn this into a couple of little stories and a couple of lessons. Now, I wrote this so recently, I didn't have a chance to commit it to memory. So I'm actually going to read the two stories, and then the lessons, I'm just going to fire them right out at you. Here we go. When cosmetic gynecology first emerged, it wasn't called cosmetic gynecology. It was called cosmetic vaginal and vulvar surgery because cosmetic gynecology, non-surgical, did not exist. These operations addressed either functional problems or aesthetic problems, or both, and they still do today. However, only a handful of pioneering surgeons were performing these operations, and everyone else was afraid. We were criticized, we were condemned by our mainstream colleagues and by academia, who simply didn't understand and lacked the foresight to see the impact of functional and aesthetic enhancements on the quality of life of otherwise healthy patients. In years past, there was a clear distinction between the gynecological medical problem, the functional enhancement request, and the aesthetic request. In years past, when cosmetic gynecology was primarily surgical, there was a steep barrier to entry in the functional space. There was little to no spillover of these treatments into the medical space. In years past, these barriers limited the pool of specialists in the functional space to those who were also experts in gynecological medical problems. And then came non-surgical cosmetic gynecology, and the barriers came crashing down, and the fear was lost. And the new paradigm is no barrier between aesthetics and therapeutics. The emergence of energy-based devices and injections that address medical issues, functional issues, and aesthetic issues has turned this on its head. Vaginal rejuvenation has disrupted the care of women, both in its amorphous definition and its semi-medical, quasi-medical, pseudo-medical applications. Stakeholders are trying to find their places. The functional space of aesthetic gynecology and the medical space of mainstream gynecology have been breached by non-specialists in these domains. But equally concerning, the aesthetic space of cosmetic gynecology has been breached by mainstream gynecologists who are neophytes in the aesthetic space. We are creating an army of neophytes, of children armed with powerful weapons. What can possibly go wrong? Meet Naomi. Naomi is the 21st century woman. She is armed with a cell phone and the confidence that she can address all of her informational needs all by herself with a few simple clicks on the internet. After all, she knows how to find the best deals on Uber, Airbnb, and Amazon. So when Naomi experiences painful sex, she picks up her phone and searches Dr. Google for painful sex treatments near her. She finds all sorts of information on Dr. Google. To separate the good from the bad, she does what she always does. She self-diagnoses herself. She looks only for the page one hits on Google for treatments. She looks for the top hits on Facebook and Instagram. And she looks for the 5-star ratings that in her mind are the metrics of quality. Naomi winds up in the office of Dr. Tango, a popular internet celebrity doctor who offers to treat her with the latest and the greatest vaginal rejuvenation machine on the planet. $2,500, he says. It's not covered by insurance, and $2,500 sounds like a lot of money to Naomi. But she agrees to pay it because so many people raved about it and about him on the internet. Dr. Tango is not a gynecologist. In fact, he doesn't even examine her. Dr. Tango puts Naomi in the capable hands of his recently hired medical assistant, Mary, who celebrated her 21st birthday last week. Naomi is uncomfortable during the treatment, just like when she had sex. But Mary tells her it's normal because that's what it says on the informational sheet taped to the wall. She goes home, still uncomfortable, still experiencing painful sex. No better, after a few weeks, she shares her story with her mom, who takes her to her gynecologist. 2 days later, the results are back. Naomi has chlamydia. She gets $12 worth of antibiotics, and her painful sex is gone. Now, Naomi is not real, but this story is the worst-case scenario of where we are today. Ignorance plus internet. That's where we are today. Patients do not have a filter to filter out the good information from the bad information. We have filters. We have years of education. We see patients all the time making mistakes. We get to evaluate. We get to do examinations. We get to do testing. Patients are being hijacked mentally before they can ever get to the doctor's office. I know which door to open. I know which treatment to provide. To them, all of the doors are gray. They all look equally valid. All right, let's get over to the doctors. The confidence that comes with being good at something does not translate to skill sets that just transfer magically to new procedures. Sure, you might be able to learn something quickly, or you may not. But there's a big difference between something looking easy and something being easy to do. The halo effect does not exist. Just because you do the best facelift doesn't mean you're going to do the best labiaplasty. Just because you can do the sacral colpopexy doesn't mean you can do the vaginoplasty, simply because technically it's easy. Less than 1% of all gynecologists, less than 1% of all plastics and urology are trained in labiaplasty procedures. Less than 1% of gynecologists are trained in aesthetic procedures. That's where we are right now. The people in this meeting are that little piece of the pie. But that's not the piece of the pie that's buying the equipment. It's more than 1%. That's a problem. Let's get back to the patient. So when a patient has a problem, they do the searching, they find the wrong information. When the patient doesn't have a problem and is searching the internet, the patient gets ideas about problems that didn't exist before they saw them on the phone and said, I think I have this problem. This creates expectations. And these expectations are created by marketing professionals who use psychology to hijack your brain. They make you want things that you don't need. They create problems. Feminine health. Okay, what's feminine health? It's nothing. But once you say you have feminine health and you have a vaginal health index, it becomes a number that needs to be treated. When we try to show the procedures are working, we have to use the numbers because we're the clinicians to see Is it a symptomatic improvement or is it a numbers improvement? In the aesthetic space, when you're charging hard cold cash for procedures, there's no number that's going to make the patient feel better if she doesn't feel better after the procedure. I can tell you, oh, look, your mercury pressure is better at your apex. She's going to say, doctor, I feel the same, and you charge me $5,000. What are we going to do about this? Keep your numbers at home. So here's our patient deciding that she wants something that she doesn't need because the internet. Walks around looking for something that she wants. And whatever she finds, she may find somebody who's good and ethical or somebody who is bad, ready to exploit. We have come to a situation where people are expecting miracles. People with the diagnosis of pelvic pain and the improvement of menopausal pelvic pain are not the same thing. That's a small subset of pain patients. So the treatments for pain are not the same for all pain. It creates confusion. Doctors are confused because if you look at the MAUD database, people were treating pain because they didn't know that it was the menopausal atrophy responsible for a specific type of pain was being improved. They just thought, oh, you can give them ibuprofen, you can send them to the pain management guy, or you can do an energy-based device. They're all the same. You have a headache, do the device. There's no good strategy. The strategies are irrational. There's no definition of success. What's a good vaginal rejuvenation versus a mediocre versus a great one if you don't have a definition? Is it a 5-star rating? I have created a little list of what things we can do to not be the demon and to be more or less the angel in the rollout of this type of procedure and therapeutics. First, we need to define what it is we're treating. Vaginal rejuvenation is what gets the patient talking and in the door. It's as if it was an aesthetic patient and say, make me look better. Just ask the patient, well, what do you think better might be? Point to something and tell me about something that you want to address, and I'll tell you exactly what I can do for exactly what you're pointing at, or that we can't do. If you're going to buy a machine that treats gynecologic problems and you've never treated gynecologic problems in the past, you can either treat them hit or miss, you can go on the internet to the ACOG website and learn a little something about the basic management, or you can tell the patient, go see your gynecologist, tell me what you got, and come back and I'll tell you what he said and whether or not we can check your box and do your procedure. Not hard to learn. Educate the patient. Now, if a patient comes in waving all this money and you've never seen all that money before because you've been working under the insurance reimbursement paradigm, it might be hard for you to not accept that patient for that treatment. But let me tell you this, what are you going to do if the treatment doesn't work because you took the money? The patient's going to kill you. Learn to pick the patient. For incontinence, let's say for instance, there is no good screening test to see who's going to respond to an energy-based device, so I do a test drive. So I have radio frequency and I have lasers. My radio frequency overhead is 5 times my laser overhead, but I know if they respond to laser, they will also respond to radio frequency. Collagen's collagen. Everything else is just details and marketing. So I give them a cheap test drive with my cheapest overhead machine at cost. If it doesn't work, we decided to gamble at a low entry point. If it works, they're going to get hit over the head with the full price, now knowing they respond. And then the goals. What is your goal? If your goal is to have a tight vagina and you have a very loose vagina, well, I got things that work and I got things that don't work. Would you like one that works or would you like one that doesn't work? And then metrics. How are we going to measure this stuff? Well, it depends. For an aesthetic procedure, the metric is what the eye sees. Not my eye, the patient's eye. So if that eye is connected to a dysfunctional brain, I'm not operating on that patient because there is no way I can logically make sense out of somebody that can't logically make sense of what I'm doing. Efficacy. This is one of my pet peeves. I see it on the internet all the time. The justification for the procedure becomes everything but what the procedure can do. Sure, they're safe. That's not an indication to do the procedure. They're easy to do. that's not an indication to do the procedure. We don't start with this because it's easy. We don't start with this because it's cheap. We don't start with that because it's popular. And then we have all these silly words. They're great in the exhibit hall because they encompass everything, and it keeps the FDA away from all those people. But if we're going to try to succeed in our procedures with our patients, we need to define what success is for each component of what we're doing. We need to define our goals. And we need to take the lead. Like we said yesterday in the energy-based panel, it's us or it's not us. Would you rather have dictates coming from people that are totally uneducated in these procedures? Thank you.